When a patient suddenly becomes hypotensive in the ICU, the most important question is not just what is the blood pressure? The real question is what type of shock is this? Because in critical care, the treatment completely depends on the type of shock. Shock simply means inadequate tissue perfusion, meaning the organs are not receiving enough oxygenated blood. Clinically, patients may present with hypotension, tachycardia, decreased urine output, altered mental status, cold or mottled extremities, and elevated lactate. But identifying shock is only the first step. The real challenge is determining which type of shock the patient has. There are four main types of shock in ICU: hypovolemic, cardiogenic, distributive, and obstructive. First is hypovolemic shock, which occurs when the circulating blood volume is reduced. This can happen due to hemorrhage, trauma, dehydration, gastrointestinal bleeding, or severe burns. These patients often appear tachycardic, hypotensive, with cold, clammy skin, and collapsed neck veins. The problem here is simple. There is not enough circulating volume, so cardiac output falls and organs become underperfused. The main treatment is rapid fluid resuscitation and controlling the source of volume loss. Second is cardiogenic shock, where the heart itself fails as a pump. This is commonly seen in acute myocardial infarction, severe heart failure, cardiomyopathy, or significant arrhythmias. These patients typically present with hypotension, pulmonary edema, elevated JVP, and cold extremities. In this situation, the volume may be adequate, but the heart cannot generate sufficient cardiac output. Management usually requires inotropes, vasopressors if needed, and treatment of the underlying cardiac cause. Third is distributive shock, the most common form being septic shock. In this type, there is profound vasodilation, meaning the blood vessels become excessively dilated, leading to reduced systemic vascular resistance. Early septic shock often presents with warm extremities, bounding pulses, and hypotension despite adequate fluids. The issue here is not volume loss or pump failure, but loss of vascular tone. Management typically involves aggressive fluid resuscitation, vasopressors such as norepinephrine, and treating the underlying infection. Finally, there is obstructive shock, where something physically blocks normal circulation. Common causes include massive pulmonary embolism, cardiac tamponade, and tension, pneumothorax. These patients may present with sudden hypotension, distended neck veins, and signs of impaired venous return. In this case, the heart may be normal, but blood simply cannot move through the circulation properly. Treatment focuses on removing the obstruction, such as thrombolysis for pulmonary embolism, needle decompression for tension pneumothorax, or pericardiocentesis for tamponade. A simple way to quickly approach shock at the bedside is to ask 4 questions. Is the patient empty? Is the pump failing? Are the vessels dilated? Or is something obstructing circulation? Answering these questions quickly can often help you identify the type of shock within seconds and guide the correct management.